I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. So, when you want to engage the neck vessels, an ideal view is LAO view. If you look at this view, this is an AP view, but you can't see the aortic arch fully opening and the origin of the neck vessels are not very obvious. But if you go into the LAO view for the same patient, now look at how beautifully the arch straightens up and opens up fully. And now you can see separate origins of the brachiocephalic, carotid, and subclavian artery. So we keep the patient's head usually straight with the chin turned upwards. Then for the carotids, you've got to see it in different views. If you look at this patient, in the AP view, you can see the disease, but in LAO view and RAO view, I think the RAO view shows you the worst possible stenosis. So it's an eccentric plaque which you can really see best in the RAO view. So you've got to see different views, different angles, and then decide about the severity of the carotid. So what I usually do is my practice is I do not ask the patient to turn his neck around. I ask him to keep his neck straight. There is no pillow under the neck. Chin is up. He keeps the neck straight. I use a biplane machine. So one of my machine, my side arm is standing in the LAO 90. That's the true lateral view. And then I go into the RAO 15 or 20. And then that's where we take our first cine like this, first DSA. And if this is not satisfactory, then we can bring the RAO one into the AP view and the true lateral moves towards the LAO. So this way in 2 injections, we can simply cover 4 views and we can see which one is the best view to work on and which gives us the maximum severity. Now, to go for the cerebral circulation, we go into the epicranial view. So we call it an AP view, but it's actually epicranial. So you can see the superior orbital rim here, and you can see the horizontal petrous bone shadow there. So what you need to do is keep going cranially till the time the superior orbital rim actually superimposes on this horizontal petrous bone shadow. So if we go epicranial, this is where you need to stop, because now this is horizontal petrous bone and superior orbital rim exactly superimposed on each other. So this is a perfect epicranial or an AP view for anterior cerebral circulation, and this is how it's going to appear. So when you take an image here, internal carotid dividing into anterior cerebral and middle cerebral artery. So this is the view that you get in this epicranial view, and this is your main working view. The other working view is the lateral view. So on the lateral view, you can appreciate the sphenoid wings of both sides visible here. So now you've got to ask your technician to move the machine, the side arm, in a way that these 2 wings actually superimpose on each other. So he moves the machine further. The 2 wings are now relatively close to each other, but still not superimposed. And then now the wings are superimposed exactly on each other. This is a perfect lateral view for the anterior cerebral circulation. And the other way is you can also ask him to superimpose the 2 ear shadows on top of each other. So that's another way of doing it. And on the lateral view, this is how the anterior circulation will appear. This is the internal carotid artery, and then the middle cerebral, and then the anterior cerebral vessels are seen here. The third view for anterior circulation is a transorbital view. So for the right side, you've got to go in the plane RAO 15 or 20 degrees, and for the left circulation, you've got to go plane LAO 15 or 20 degrees. So no cranial or caudal angulation, it's just plain RAO or LAO. So for the right one, if you go into the RAO, keep going into the RAO till the time this white shadow appears right in the middle of this orbit. So this is the optic apex, and you want to bring it right in the middle of the orbit. So what you will see then is this is an ideal view to look at the bifurcation of internal carotid artery. So the bifurcation very clearly opens up here, and at times it's easier to appreciate things if they are not very clearly visible in the epicranial view. For the posterior circulation, again you've got to go deep epicranial, and you call this Townes view, and you keep going epicranial till the time you have this bat wing appearance visible to you. You can see this is like a bat wing appearance. So once you see this appearance, this is a perfect view for the posterior circulation, and it will appear like this. You've got the vertebral artery, the basilar, the posterior cerebral, everything opens up very nicely. For the vertebral arteries themselves, you can have either an AP view, or you can add on a biplane this true lateral LEO 90-degree view, and you can see all the bends and the angulations and the tortuosity that you have to traverse with your catheters. How to make all of these views? I've given a page in your booklet in which I have written down and shown you the technique of doing all of these views. Now, what is important in angiography, cerebral angiography? You've got to use DSA. This is very important. Ideally, you should use a biplane, makes your life very easy, and you should use roadmap. This is a nice technology, static arteries. So you've got an overlay, you've got a still image behind, and you are working on top of it, superimposed on the roadmap. So makes your life very easy and safe. You've got to have continuous flush going on. As I explained, there's no heparin on board, so you don't want your clots to form in your catheters. And then once the flush is going on, you've got to be careful to avoid air embolism. You must record till the venous phase, because you've got to take long recording till the venous phase. That's when the collaterals will appear. You've got to look for collaterals. You see, in the late phase, you will see the collaterals appearing, and furthermore, they are increasing and increasing. Same thing is shown here, that MCA is blocked. This is 0.7 seconds. At 1.3 seconds, you start seeing some vessels appearing. At 3.3, you are looking at more vessels. And then a lot of circulation is now visible here at 4.3 seconds. So take long recordings of TSA when you want to look for the collaterals. Thank you.